With respect to the questions that were submitted prior to this meeting, I have a few, and I don't know if Dr. Nangalia is going to be available. I do not see her on here, but some of the other speakers may be able to answer some of these questions. Here's one that we commonly get from patients, and I think anyone here on the screen is probably able to answer this. What is the significance of the JAK2 allele burden? Does testing positive for JAK2 alone confirm MPN when other criteria are not met? And I think I'd like to focus on the allele burden question, because some of our reports will come back, you have 10%, you have 50%, you have 72%. And if you happen to know that number, does it matter to follow it and track it? And for that matter, is there much discordance between the bone marrow JAK2 allele burden and the peripheral blood? Anybody want to bite?
Well, I'll take a shot. Because we wrote a paper on that, so it must be wrong. Actually, no. In general, I think in general, measuring the JAK2 allele burden in the peripheral blood is an index of extent of and severity of disease in general. However, we have followed many patients with polycythemia over the years who have high allele burdens and who are doing very well symptomatically and on physical exam have limited disease. That is to say, they don't have an enlarged spleen, they have relatively normal blood counts, and have an excellent performance status, emphasizing what Ruben, in his usual articulate excellence, has pointed out, that you have to look at the whole picture of a patient who presents various clinical and laboratory signs. In contrast to the French, our good friend J.J. Kalajian, who discontinues interferon if the level of JAK2 allele burden is low, we have found that if you do bone marrows on such patients, and we follow our patients with frequent marrows, as frequently as they allow us, we have found that patients who have low JAK2 allele burdens, for example, in polycythemia vera, may have very hypercellular marrows, and in fact may have significant degrees of fibrosis. And we consider that of clinical importance because we then would continue interferon, and then if you follow those patients for another few years, you will see a decrease in the fibrosis, and the cellularity, with no significant change in the JAK level, which remains low. So, in summary, we don't find the JAK of and by itself an indicator of disease progression, but it has to be confirmed by marrow findings. It has to be confirmed by evaluation of many of the things that Ruben has said. And it doesn't apply as closely in polycythemia vera probably as it does in myelofibrosis. Serge may want to comment on that. But certainly in polycythemia, it is not the be-all and end-all from which we make a decision. From a diagnostic standpoint, on the other hand, it is very, very, very uncommon to find a patient with true polycythemia vera who in this day and age does not have a demonstrable JAK abnormality. There are other causes of erythrocytosis, as we all know, but most of the laboratories now have very good standardization techniques. So if a patient is JAK negative with a relatively high blood red cell count, we look for other causes other than polycythemia vera.
Thank you. Ruben, do you want to comment on JAK2 itself, and in your practice, do you monitor it?
So we are getting the information now when we check it. I think it's still a marker that we don't know how to fully utilize. I think, we know that other markers like this in chronic myeloid leukemia have been helpful. But in chronic myeloid leukemia, we see people decrease almost 1,000-fold their level of their allele burden. What I don't know is, by decreasing the allele burden from 70% to 30%, does that really mean anything? I don't know at this point. I think by far the most important things that we do monitor are how the individual is doing. I think that tells us a lot. How the blood counts are doing, and whether there is any suggestion of progression toward acute leukemia, particularly if there's additional genetic mutations that develop, such as ASXL1. I suspect all of those things probably are more impactful at the time being than the allele burden.
Thank you. Here's another question. How important is genetic testing for an individual in terms of determining their therapy and their future prognostic risk? And maybe I can add that when we do a bone marrow biopsy, for example, we can just look at the histology under the microscope, but we can also order chromosomes like the pictures that Dr. Nangalia showed us of the 46 chromosomes, and if there's others and mutations. But then there are these molecular abnormalities. In our institution, we use a tool called next generation sequencing. And it may take up to 2 or 3 weeks to get these results back, but you'll get a panel of up to however many your panel orders. Ours is about 42 genes. And it has these mutations, ASXL1 and CALR and et cetera, IDH2. We know that there are some prognostic scores for myelofibrosis, for example, where these are used, the GIPS score, so-called. But what about in ET and in PV and in myelofibrosis? And is it important enough that when a patient's insurance company says, I ain't paying for that, which they still say sometimes, that we have enough literature to argue in favor of getting these, and should we do them on everybody? Oh, look, I see Dr. Nangalia here.
Yep. So, John, why don't we have her chime in? And I see as well if Joanne can bring forward Dr. Kalajan, you can kind of demote me and put me back in later as need be. But for us to hear from Jean-Jacques while we're still at a reasonable time, Paris time. But Yoti, what are your thoughts on that question?
Dr. Nangalia can hear us?
Hello? Yes, I can hear you now. It was frozen before.
Oh.
So, Dr. Nangalia, let me repeat the question. I'll make it shorter. What's the value of getting, say, next generation sequencing or panels of molecular mutations and chromosomes in patients, whether it be ET, PV, or myelofibrosis, for prognosis and for therapy? Is it, in our country, sometimes our insurance companies will say, we're not paying for that, it's experimental. Do you consider it standard practice, and how important is it to get these and to monitor them in a clinical world, not in a research world?
Exactly. I think we have similar issues in the UK in that because everything is NHS funded, we have to justify why we're doing something. I think there'd be 2 reasons to do NGS, next generation sequencing studies in patients. One is to inform the patient of their prognosis. I think now work that we've done in many other groups have shown that if you combine all the factors that we can see about a patient's disease with their genetic testing, you can quite accurately inform patients about their long-term prognosis, both in terms of lifespan as well as in terms of their risk of disease progression. So there is that aspect of it may not change therapy and it may not change what we do, but it may be useful information to the patient who might want to know. Then there's the other aspect of in what circumstances might it be useful to the clinician in terms of changing therapy. And I think patients with advanced disease, myelofibrosis, in whom one might consider more aggressive therapies at an earlier stage, in those situations, I think all clinicians would want to have extended sequencing to inform treatment decisions, as Serge has mentioned already. In terms of ET and PV in patients,
Sounds like she froze up. Can anyone else still hear her?
No.
No.
but the trouble at the moment is we don't have any therapies or anything to offer. So that would be in the context of a clinical trial.
So there are 2 possibilities for influencing the management of the patients with the extensive genetic testing. One is related to inability of JAK inhibitors to work very well in patients that have complex genetics.
Mhm.
That has been shown by several groups. You have still very good chance in controlling the symptoms and signs, but not for too long. So having multiple genetic abnormalities shorten that period of time and certainly influence your decision to go to the transplant sooner rather than later. The second is when you are progressing to accelerated or blastic phase. Remember, 10% or more, 10 to 20 is accelerated phase, 20 or more is acute myeloid leukemia phase. There is acquisition of certain mutations that have been associated with that transition to accelerated blastic phase, and particularly IDH mutations. In 20 to 25% of the patients, IDH mutations become visible, if you like, on the testing. And there are IDH mutations. Inhibitors are on the market in the United States. We have used it. We published, others published using IDH inhibitors in accelerated blastic phase. So that's not trivial, 20-25% of patients, because it can help them a lot.
Yeah, I agree completely with Serge. You and I have both published that if you have 3 or more of these mutations, the chances of responding in myelofibrosis to drugs, and especially interferon, is highly unlikely. And certainly that's an indication for transplantation. And then you can make drug-specific therapy as the IDH inhibitors. Absolutely. And the last thing is that it's a poor prognostic sign. I think we should add that it's much more common in myelofibrosis than in PV, and certainly more common than in ET, which is rare.
I noted that Dr. Kalajian, who isn't on screen, answered and made a comment on the sidebar about interferon, and I'll just read what he said. He says, and I can't use the French accent very well, but I will discuss this afternoon the results and outcomes of patients after interferon that will discontinuation that will complement Dr. Silver's explanation. In particularly, we, Dr. Kalajian, found that the quantity of JAK2 mutation reduction is an important predictor of the chance of remaining well without further therapy. And that was a comment he made on the side. There is a question for all of us in general that is going to come up, and maybe we can ask later, but some of you face this almost every day. A patient comes in, they ask a question about COVID, right? And as clinicians who all see these patients, what are you telling them about the safety of the COVID vaccine at this point? And then this is a question from a user: how long after transplant should we wait to get the COVID-19 vaccine?
So I suggest everybody, all the patients, to get the COVID vaccine unless there is some kind of a contraindication that I'm not really aware of, because the risk of dying and having complications from COVID in patients with MPN is increased. COVID comes with increased thrombotic risk. MPN has increased thrombotic risk. You just put 2 and 2 together, and you know that complications are serious. I mean, many of my patients, unfortunately, has been affected and seriously affected, and we have a number of patients that died from the complications. So there is no question in my mind to encourage everybody to get the vaccine. And specifically for the transplant, I don't really have experience to say. I know that people who have had a COVID infection should wait for 3 months to get the vaccine, but for the transplant itself, I don't have experience to answer.
A question that I often get asked, and I'll ask this for the group, in light of the fact that interferons, including pegylated versions, were used in China as part of their treatment regimen for COVID in some publications, and in light of its antiviral effects, but also in light of its sometimes suppression of leukocytes and so on, what should we tell a patient who is currently on interferon, or for that matter, hydroxyurea or ruxolitinib, and whether this puts them at risk or whether they should continue the drug in light of COVID infections? You know, they get admitted, they get positive. Should you stop the drug? Should they stop it so they don't get infected? What are the advice of people?
Well, you mentioned Rux and Hydrea and interferon, and of course those are 3 different acting drugs. But so let's. I don't think they. I mean, other than what Serge said about the risk of MPN patients, the risk and mortality, morbidity is probably a third more than patients in general. So we would strongly endorse patients receiving COVID vaccination. And I strongly agree with, endorse what he said and encourage patients to get vaccinated. But the idea of using interferon in COVID was something that came up very early in the course of this epidemic, not only with us, but abroad in Europe. And unfortunately, we couldn't convince our infectious disease folks to launch such a trial in our own institution because they don't use interferon very much. So the second part of that is interferon has to be used early in the course of the illness rather than late, just like in hematologic disorders. Because if you get an overwhelming infectious burden, then interferon is not going to be effective. And third, as we all know, some of the side effects or after effects of COVID is probably due to an interferon inflammatory response. So we wouldn't certainly want to use it in an advanced stage of disease. There's been one trial in England with beta interferon, and that got equivocal results. And so the bottom line is there has been no controlled trial that I'm aware of that has shown interferon to be of benefit, although it's a very intriguing subject. And you have to catch the patient early in order to be effective, and that hasn't been done yet.
In terms of the patients that are on the therapy, that's
continue it, absolutely.
Yeah, you need to continue. Actually, we are all aware of a recent paper that the discontinuation of ruxolitinib at the time of COVID infection increases the risk of dying.
Right.
So we don't want that, right? You want to continue therapy, whichever you are, without interruption.
And it's interesting that patients who have been on interferon for MPN say they have fewer infections. And that's a clinical observation. It's never been proved.
Dr. Kalajian, we see your happy face on the screen, and I'd like to close our question and answer a bit earlier. There's so many more questions, but we got to get back on schedule. But because we just saw you, I'd like you to make any comments you'd like to make about these questions of interferon, and you already said something on the sidebar. Maybe you'd like to speak for us just a second about that.
We'll discuss maybe this afternoon if we have enough time after the session. But about the COVID and treatments, we are currently analyzing a cohort of 1,800 patients who were followed for 1 year since the beginning of the pandemic. And if we have enough patients, we will see if one treatment like interferon or other may have prevent or reduce the severity of COVID infection in our patients. So we'll see. And thank you, and see you this afternoon.